Hello, I'm Shayna Oshita. I'm a registered dietitian and certified diabetes care and education specialist. I am a clinical assistant professor and director of the coordinated program in dietetics here at UIC. And today we are going to talk about how diabetes nutrition management and dietitians and medical professionals can work together to help patient outcomes. So really the physician is the start of the process of education in most cases because patients are going to be coming to their primary care physicians, doctors' offices, hopefully on a somewhat regular basis and getting screened. And the identification of any blood glucose issues, it will hopefully be realized at these visits. And when the diagnosis is given, whether it be for prediabetes, type 2 diabetes, type 1 diabetes, gestational diabetes, etc., there are certain things that the physicians can do in order to help start the process and make it easier for the patient to work through a difficult diagnosis. So one of the things is emphasizing the importance of healthy eating and exercise. To give patients just very basic instructions for going home in both verbal and written instructions will really help their understanding in case they prefer one route or the other, or it helps to reinforce the messages. And then I'll place referrals to the dietitian or the diabetes educator that you have either in your system or have some on record for referrals so that this process can be done quickly and they can have their appointments as soon as possible. One of the biggest things that patients with diabetes, people with diabetes struggle with is the lack of initial education. Some people don't get referred to dietitians and diabetes educators for various reasons. And so the primary care physicians or physicians in other areas can help to make this process a little bit easier by one, diagnosing the disease, and then also being able to explain food and diabetes in a simple way in order to help them understand. Some of these are going to be like foods that how they get digested. So they get digested and turned into sugar in your blood. Insulin is made by the body and helps to get the sugar into your cells so your body can use it for energy. And so in this example, we are trying to simplify the language and not use a lot of very technical terms to help people understand. And then when we think about the food specifically, which foods are going to turn into sugar? So all foods are made up of three things: carbohydrates, proteins, and fats. Some have more of these than others. But in general, carbohydrates will raise your blood sugar, proteins and fats will not raise your blood sugar. So again, this isn't a simple message to try and help them understand what food groups are doing to their blood sugar levels in their body. Some other things to think about as a physician, we're not necessarily going to be talking about macronutrients, using those terms with the patients right away. But in general, from our perspective, from a nutrition professional perspective, macronutrient distribution should be individualized. There is not really any ideal percentage of calories from carbohydrates, proteins, and fats for any one person with diabetes. So the general recommendations are going to be 45 to 65% calories from carbohydrate, 20 to 35 from fat, and 10 to 35 from protein. So now we're going back into how to talk to the patient about different groups of foods. So you can tell them, remind them, carbohydrates are the foods that are going to turn into sugar when you eat and drink them. Carbohydrates include wheat products, any breads, pastas, cereals, grains such as rice, quinoa, any kinds of fruits, any kinds of vegetables. But with vegetables, those are divided into starchy and non-starchy vegetables. So the starchy vegetables are going to have a bigger effect on blood sugar levels because the starch is going to turn into sugar. Vegetables that are non-starchy don't have a lot of starch, so they're actually not going to raise the blood sugar that much. And the nice thing is there are a lot of non-starchy vegetables. Non-starchy vegetables would be things like greens of any kind, broccoli, string beans, peppers, zucchini, all of these different things. Starchy vegetables would be things like potatoes, corn, sweet peas, and winter squashes. Other things that will be higher in carbohydrates will be things like milk and yogurt, so the more liquid dairy foods. So the general recommendations for carbohydrates is to eat a variety of starchy vegetables, fruits, whole grains, legumes like beans and dairy products, to try and monitor carbohydrate intake and keep it more consistent throughout the day, because this does show an improvement in glycemic control and people can be more consistent with their portions. We want to encourage limiting sugar-sweetened beverages, and the intake of fiber is still the same as the general population, so we want to encourage high fiber through non-starchy vegetables and whole grains and legumes as much as possible. For proteins, we can remind them that proteins don't really affect the blood sugar levels, but for heart health reasons, we do want them to choose lower fat versions of these proteins. So proteins are going to be mostly from animal sources that are lower in carbohydrates, so or have no carbohydrates. So chicken, turkey, fish, and eggs are those that are preferred, especially the white meat or the breast meat. And then for pork and beef, choosing leaner cuts of those. Anything that has the word loin in it generally has a lower fat content. For those that are vegetarian, we can certainly encourage protein sources like soy and beans, but we do have to warn them about, starchy beans like legumes are going to have a higher carbohydrate content, which is fine. Some things for the physician or the healthcare professional to keep in mind: if patients have diabetes and no sign of kidney disease, there really is no evidence to modify their protein intake. If they do have kidney disease, depending on their level of kidney disease, we might have to adjust the protein intake slightly, but not really below the usual amount, because it's not going to change any kind of glycemic levels. Some studies have shown that an increase in protein can improve glucose and insulin concentrations, reduce appetite, and improve satiety, but it's not really adequately studied at this point to make a blanket statement. And we do not use protein sources to prevent or treat hypoglycemia. Going back to patient-centered, for fats, examples of heart-healthy fats are olive oil, canola oil, nuts, margarines, things that are a little less heart-healthy and should be limited: butter, cheese, shortening, and lard. And we can remind them as well that fats do not raise the blood sugar. From a healthcare perspective, healthcare professional perspective, fat goals should really be individualized. But again, the general recommendation is 20 to 35% of total calories. The amount of saturated and trans fat is the same as the general population, so we want to really limit both of those. High monounsaturated fatty acids may decrease cardiovascular disease risk factors in type 2 diabetes. So again, encouraging nuts and plant-based fats are going to be a good recommendation there. And also to try and eat fish, especially those fish that are high in omega-3 fatty acids like salmon, at least twice a week. And these are the same general recommendations for people without diabetes as well. Sodium, again, is the same for the general population, about 2,300 milligrams per day or less. If the patients do have diabetes and hypertension, based on what their needs are, what their blood pressure might be, what their medications are, they may need to have more reduction in sodium. Alcohol recommendations: people can still drink alcohol, With diabetes, the general recommendations are 1 drink per day for women, 2 drinks per day for men. This is more based on body size than actual gender or sex. 1 drink will equal about 12 ounces of beer, 5 ounces of wine, or about 1.5 ounces of distilled spirits. Alcohol can cause hypoglycemia because the liver is processing the alcohol as a priority over releasing glycogen stores in response to low blood sugars. So our emergency backup, if it's basically not working. It can also mask symptoms of hypoglycemia. So we do want to make sure that people are not drinking on an empty stomach, that they have alcohol with meals or snacks to try and prevent hypoglycemia. And usually, alcoholic drinks do not require insulin. However, some of the mixed drinks with sugary, high sugar content may need some insulin for that. As far as meal spacing, we're recommending that if someone is using nutrition as a monotherapy and not on any oral agents or insulin, that 3 meals a day or small meals with snacks is recommended, again, to keep that carbohydrate intake consistent throughout the day. But this can be individualized, of course, based on patient schedules and their preferences. If people are on oral agents, we want to keep the meals still about small and moderate in size. Snacks are not generally needed, but could be accommodated, again, depending on the person. And consistency is also stressed in this situation. And then if someone is on insulin, depending on the type of insulin and their insulin regimens, we're going to possibly be doing more individualization here. So again, trying to keep the amount of carbohydrates at a meal and meal size about small to moderate. If someone's on a fixed insulin regimen, so certain fixed doses, especially of fast-acting, rapid-acting insulin, we want to emphasize consistency in meal timing and carbohydrate amounts. If someone is on an intensive or flexible insulin regimen with fast-acting or rapid-acting insulin, we're probably going to be dosing based on the carbohydrate content. If someone is not on any fast or rapid-acting insulin and just on long-acting insulin, then they can follow the recommendation for nutrition therapy with oral agents. So here's a summary of the medical nutrition therapy recommendations for people with diabetes. Portion control is recommended for weight loss. Carbohydrate-containing foods and beverages are the greatest determinants of post-meal blood glucose levels, which is why consistency and portion control is very important. And when choosing carbohydrate foods, choosing nutrient-dense and high-fiber foods as much as possible, trying to avoid or limit sugar-sweetened beverages, limiting saturated and trans fat, choosing lean meats whenever possible. There really isn't a lot of evidence to support supplements and herbs in management of diabetes, so those are not necessarily recommended. Limiting sodium to about 2,300 milligrams per day, and moderate alcohol consumption. Portion control, again, is key. We keep talking about it, and we really don't want people to feel like they can't eat anything. We want to try and have foods available for them to consume, the foods that they enjoy, the foods that they like, but in ways that are going to benefit their diabetes management. So don't recommend any removal of major food groups, using terms like white foods are bad, don't eat bread, don't eat carbs. These are not helpful. They usually stress people out, and they're really not necessary. We do want people to eat bread. We just don't want them to eat loaves of bread at one time. So it's more about the amount of foods rather than the types of foods that need to be emphasized. Suggesting limiting sugar-sweetened beverages and sweets is always a good recommendation, but there is room in someone's meal plan for these things if they really enjoy them. And promoting just eating more fruits and vegetables, drinking more water is going to be helpful. For meal planning, there are a few different ways for meal planning recommendations. We can use MyPlate through USDA. This is really good for kids and people with prediabetes because fruit and dairy are on this example, and those are going to still be foods that are higher in carbohydrates. So for my plate, we want to use a 9-inch plate. A quarter of the plate is full of non-starchy vegetables, a quarter of the plate with fruit, a quarter of the plate with a lean meat or some kind of plant-based protein, and a quarter of the plate with carbohydrates. A second method is helpful for people who are watching their weight, trying to lose weight, maybe on oral medications or long-acting insulin only. Still, we're looking at a 9-inch plate, so we're trying to watch the portions. But in this case, we don't have the fruit and the dairy in separate groups. So half the plate is non-starchy vegetables to encourage higher vegetable intake. A quarter of the plate is our meat, protein, and healthy fats. And then a quarter of the plate is carbohydrates. And this is including the dairy and the fruit in this section. Another option is for carbohydrate counting. Carbohydrate counting can be very helpful in some cases because carbs are going to be the main nutrient affecting blood glucose levels. It could help with weight loss. If some oral medication someone is taking cause hypoglycemia, this might be helpful. And also, if someone is taking insulin, the fast or rapid acting insulin, this is really going to be helpful to maintain tighter blood glucose control using an insulin to carbohydrate ratio. But it does require a lot more frequent self-monitoring of blood glucose. And it is more precise, but it can be flexible. So this is nicer. But some people have difficulty counting carbs and doing the math. So they could be taking fixed amounts of a faster rapid acting insulin and then having fixed amounts of carbohydrate to match along with that. So it really depends on the person, what way is going to work for them. But these are some ways of counting carbohydrates if that is preferred and decided upon by the patients and their caregivers. So there are 3 different ways of counting carbohydrates. There is the diabetes exchange or carbohydrate exchange system, which is a little bit older. Carb counting in servings, so having servings per meal or carbs per meal, and then gram counting, where we count the actual grams of carbohydrates. And the gram counting is where we would use an insulin to carbohydrate ratio. So in the diabetic exchanges, foods are grouped into basic types, carbohydrates, proteins, and fats. They're allowed number of servings from each exchange group. They have different foods in these groups, and they can be exchanged based on the same amount of calories and other nutrients in these foods. And carbohydrate exchanges, again, as we've talked about, consistency with carbohydrate intake, they are spread throughout the day, and people are given amounts of each group that they can have. So this might be familiar to you. You may have heard it. Sorry, it's a little blurry. But within the carbohydrate group, you can see here in the starches and fruits, there's about 15 grams in each of those. The protein varies. The calories are going to vary. For milk, there's a little bit lower grams of protein or grams of carbohydrate, but it's essentially the same. For meats and meat substitutes, they're a little lower. You can see no carbohydrates, the amount of protein, and then the fat's going to vary in those. So people would say, okay, you can have, so many number of starch servings, fruit servings, milk, very lean meats, and fats per meal or throughout the day. The exchange system can help with weight loss because also through controlling portions, you are talking about calories as well. With consistency of carbohydrates, it's helping with blood glucose control, but it is a little bit more difficult keeping track of calories and proteins and fats and all these different numbers. So it can be very overwhelming, and the tables can also be overwhelming just for them to look at. There are also some contradictions in the exchange list for beans because it's a starch and a meat, and peanuts are a meat and a fat. So there are some things to think about that can get confusing. Most people are going to find better glucose control through carbohydrate counting, either with servings per meal or grams per meal. And so the patients are primarily focusing on the total amount of carbohydrates at each meal without really worrying about calories. And by doing carbohydrate portion control, they are usually also able to have some weight loss. So generally speaking, women would have 3 carb choices per meal, or men with 4, 1 carb serving per snack. Now, when we're thinking about grams versus servings, 1 carbohydrate serving equals 15 grams of carbohydrates, and that can be shared with them. Or if math and numbers seem to be a little overwhelming, it can be not discussed right away. Non-starchy vegetables, meats, and fats don't raise blood glucose, and they do not have to be tracked. We want to emphasize, though, that meats and fats are not free because of the extra calories and the impact on the heart health. So this doesn't necessarily have to be mentioned in the very beginning, but can be addressed later. And it also does require blood glucose monitoring to see how the plan is working. So it is more detailed than the plate method, but it helps keep the ideas simple, and it can help improve glycemic control. When we're looking at this, you would share maybe a list of, these are all a single serving of carbohydrates, and they can look at the list and see which foods they like and which foods they don't. You can talk about meal examples and see what they like and what they don't, and how to do some maybe shifting of carb servings if needed. Another way to think about portions is, they always have their hands with them. So using the helping hand to think about measuring or figuring out portions if they don't want to measure. Using things that they might be familiar with, like a deck of cards or dice or like a tennis ball, to give an idea of portions. These can all be helpful. And this is also helpful when we think about carbohydrate counting in grams. When we do focus on grams instead of other methods, it does liberalize the meal plan a lot and gives a lot more flexibility. It is the most advanced method of tracking carbohydrate foods and portions. It can, when used appropriately, give best results in glycemic control, but it is a lot more work. So that's something to think about if it's appropriate for that person or not. Carbohydrate gram counting, food labels is helpful, not only in gram counting, in other methods as well, but the carbohydrate information on the labels is in grams, so this needs to be brought up. So we want to try and simplify the food label for them as much as possible. So when looking at the serving size, find that first. The grams next to that can be ignored because that's the weight of the food. It has nothing to do with the grams of carbohydrates. And then the serving size is what the whole label is based on. We want them to look at the total carbohydrates, not just the sugar, because the sugars and fiber are included in the total carbohydrates. Foods that are sugar-free or labeled sugar-free does not necessarily mean they are carbohydrate-free. And when thinking about carbohydrate gram counting, the recommendation is about 45 to 60 grams of carbohydrates per meal. So just a quick recap. In general, we want to always pick the method that is best for the patient, and thinking about what they like to do, what their schedule is, what their medication regimen may be, and help them decide for themselves what is going to be the best way to manage their meals. Introduce the concepts of carbohydrate foods and portion control, but again, thinking about the method that's going to be helpful for them, whether it's the plate method, which is very simple and easy to deliver quickly in clinic, the exchange system, which is really long and could be overwhelming, the carbohydrate choices or carbohydrate grams. So plate method is usually the one that we would recommend for adults using the diabetes plate method, where half the plate is non-starchy vegetables. This is a good starting off point, and then upon subsequent visits, referrals to dietitians or diabetes educators, we can go over things in more detail and help them really understand things for themselves. So this is just a really brief simplification of things that can be brought up initially with people with diabetes, whether they're new to diagnosis or maybe have had diabetes but not had a lot of education about it to really make a big impact on their diabetes management without trying to overwhelm them too much. Here is a slide with some resources. And then also, if you have any questions, certainly ask our nutrition students, but you can also email me to help with any further questions that you have. All right, thank you so much for your attention. Enjoy the day. Bye.